Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming.
With regard to adjuvant therapy, there's some interesting data that's come out of neoadjuvant data in melanoma suggesting that immune therapy given when there's a lot of T cells around in the tumor works better than after you've done a resection and there's no measurable disease. And then there's data from the personalized cancer mRNA vaccine in melanoma, which suggests that if you increase the number of T cells around by giving vaccination together with Pembro in the adjuvant setting, it does better than Pembro alone. And I think we have ample evidence in kidney cancer that we're not getting as much benefit as we thought from giving treatment in the adjuvant setting in terms of activating the immune system. And so maybe because we're not don't have enough T cells around to activate and kill the tumor, we could still give anti-PD-1 in patients who've progressed on adjuvant therapy when they have more T cells around that could potentially treat the tumor.
Again, I don't know if there's going to be other trials to answer this. We have contact, flatly negative. Tanivo, we'll see. I don't think any of us would predict that it's going to be wildly positive. Maybe you would.
So that's where the real world outcomes and things like Odyssey that we track over time, things like IMDC database will really help us inform sequential use and how these patients are doing over time. So no company is going, and no cooperative group is going to follow those patients through 3 lines of therapy. I wish they would, but real world data will help us.
So appreciate all. This has been a really interesting discussion. Again, I feel like we could probably talk here all day about this. And I think just to summarize, we have important IO-TKI longer-term follow-up. I think it probably introduces some questions around durability. I don't think any of us said it was going to wildly change our practice, and don't necessarily think it's going to change a community oncologist.
I did say it should change your practice.
Say it should. And I don't entirely disagree. And this is why it's super important to have these follow-up presentations and publications and these discussions. And then in the second line setting, contact, probably the most practice impacting data, even though negative, right? Negative studies can be really important. And this is one because it was happening and it doesn't ask and answer every question, right? PD-1 inhibitors, time since prior therapy, et cetera, that we outlined. But I think it really should, put to an end that practice of sequential immunotherapy as it was given in the trial, leaving aside the far away from adjuvant or other things. So again, thank you all for joining us. It's been an interesting discussion.
Thank you.
Thank you.